Chief Legal Officer with Aegis Sciences. Let me just make sure I'm in control of this. Yes, I am. And with me is Dr. Elaine Jeter, our Medical Director. Today we're presenting on a test. It's a PLA code that we requested coverage on, is the underlying application for a test called INTERACT-RX, a definitive diagnostic drug-drug interaction test. So I want to thank you all for being here, and thank you to Palmetto GBA, and especially the medical directors and the administrators that have worked with us for the past year plus, and bringing this to fruition to where we are today, which is a draft policy. The draft policy is currently for non-coverage, but we want to speak to some of the points that we believe led to that non-coverage draft and see if we can overcome those on a go-forward basis. With the increasing use of medications in treatment and polypharmacy trending upward for the last several decades, in conjunction with the potential for drug-drug interactions, the need to manage prescriptions and avoid serious iatrogenic harms created by physicians prescribing drugs to patients and by patients taking drugs that aren't disclosed, either intentionally or unintentionally, as well as food substances and over-the-counter medications and herbal supplements. There's never been a greater need for interaction methods to detect drug-drug interactions and drug-substance interactions. Unfortunately, this is a trend that has continued upward and will continue upward into the immediate future with the increasing use of medications and polypharmacies. It has been demonstrated, it's commonly understood, that drug interactions are a significant and preventable cause of adverse drug events. The drug interactions, especially in the elderly population that Medicare Cares has jurisdiction over, are a significant source of morbidity. For myriad reasons, there are significant deficiencies and gaps in the current standard of care for obtaining accurate medication lists and identifying potential drug-drug interactions in the medication management process. There are numerous studies on this point. They show 20, 30, 40, 50% or more of gaps in the current process, that drug interactions are not being detected despite physicians having a standard of care of taking medication history and reconciling with pharmacy reconciliation reports. Polypharmacy, especially in the elderly, continues on an upward trend, and polypharmacy, especially in the elderly, directly and proportionately leads to drug-drug interactions. Polypharmacy is defined commonly as 5 or more drugs taken by a patient. When patients are in the 5-6 drug range, there's an 80-90% chance of a drug-drug interaction being present. Each of these points is evident not only in abundant literature, but these points are correctly made in the draft coverage policy. In this regard, the draft policy further recognizes correctly that it is necessary to perform medication management for improved health outcomes. It is part of the standard of the care. The draft policy does indicate that medication management is a necessary process, and through that process, drug-drug interactions are discovered and they are managed. However, going to the third bullet here, there are significant gaps, as we've discussed. That is also recognized in the draft policy. As I said, study after study shows upwards of 50-60% gaps in taking medication lists from patients. All that said, drug-drug interactions are a significant and preventable cause of morbidity, adverse health outcomes, especially in polypharmacy and elderly patients, and that too is recognized in the draft policy. With those points, we think the need for this test is very well demonstrated, and we have done studies on that. We're going to speak to those. There are a couple of oversights, 3 in particular, that we want to really call out and have a conversation and discuss with respect to the draft policy. The 3 critical oversights that we see are, first, the issue of screening. We agree and readily acknowledge that MACs cannot authorize coverage for a screening test. That is known. However, with respect to the coverage that the applicant requested, we did not ask for INTERACT-RX to be covered as a screening test. Instead, we proposed coverage limited for patients exhibiting signs and symptoms of a drug-drug interaction. And we also proposed a further limitation that in addition to the signs and symptoms, the test can only be ordered after a physician exhausts the standard of care methods of discovering drug-drug interactions, such as taking the history, medication reconciliation, alerts, and reports. With these things in place in advance, this is not a screen that we are asking coverage for. Patients are suffering signs and symptoms of a DDI. The physician has a belief that there is a DDI adverse event occurring and has not been able to diagnose exactly what is causing it and how to manage it, and therefore needs to order the test. We have performed many studies in this regard, retrospective and prospective studies. With Dr. John Peabody at Cure, we performed a prospective random controlled trial that we're going to speak about. Dr. Peabody is also going to speak today. Through that trial, we showed that 40% more drug-drug interactions are identified with the test results plus utilizing the standard of care as compared to just the standard of care alone, which is taking medication histories and reconciliation. Despite this finding, and this is the second point of the oversight that we wanted to call out, despite this aspect of the study, the draft LCD concludes that we found no evidence comparing drug interaction testing to an assessment for interactions based upon medication history, which would likely be the appropriate comparator. And we 100% agree with that. That is the appropriate comparator, and that is the principal part of the Cure study, which was to compare those physicians that had the standard of care and utilized that, plus the test, to those physicians that only had the standard of care at their available to them. With that, there were 40% more drug-drug interactions identified, and I'll get into further findings of the study next. But on this regard, this being the appropriate comparator, what we found in this two-part study was that 99% of physicians in the study did report that they regularly reconciled medication lists and assessed patients for drug-drug interactions as part of their everyday standard of care. So the physicians were doing both components of it, and only those that had the test were compared against the control. Additionally, on this point, Table 8 of the study findings, the clinical utility of definitive drug-drug interaction testing in primary care, Table 8 of that publication shows that physicians were monitored and scored based upon their use of the standard of care of doing medication reconciliation. And what it showed was that the control group and the group that was performing the standard of care plus you had the test performed the same statistically with respect to the medication history component of the test. They performed statistically the same, so they were both acting similar with that respect. The third point is, and this gets more into a technical regulatory issue, is what the current standard is for granting coverage. And we believe that the policy has overlooked regulatory precedent for a factual demonstration of clinical utility of a test, the result of which changed physician behavior in a manner that has been previously demonstrated to improve patient outcomes. There are numerous national coverage determinations. I'm going to turn it over to Dr. Jeter, let her talk through some of these briefly. National coverage determinations that follow this standard. Plus, some of the draft policies on the agenda for today, I don't know that there's speakers on them, excuse me, but some of the draft policies on today's agenda are also following this standard. They too do not require a patient outcome study, instead propose coverage on tests which are demonstrated to be approximately equal to alternate tests that are known to change physician behavior. And our test meets the standard in spades as far as changing physician behavior. It helps them find the DDIs, but there were significant management changes that we will speak to. With respect to these other studies, we're not suggesting in any way that these other drafts on the agenda were decided wrongly. Instead, we think they are decided rightly, each on their own merits. But those tests, this is a diagnostic test, which should be held to probably the lowest standard. This is the only diagnostic test. It's a definitive diagnostic test on the agenda today. All the other tests are predictive or prognostic tests. Ours is, and they are molecular tests. Ours is, again, not a molecular test. It's a toxicological test, definitive toxicology test. With that, I want to give one example. I'm going to turn it over to Elaine to discuss the NCDs and maybe some of the LCD language on the standard. But an analogy that we think is the perfect analogy here is monitoring for a cholesterol level. A cholesterol level, like a drug-drug interaction, may be deemed, there's different terms that could be called, but an intermediate health outcome is often the phrase used. And intermediate health outcomes can be sufficient to grant coverage if there is a known pathway to an actual health outcome. And the reason cholesterol levels and cholesterol level tests are an appropriate analogy is because cholesterol levels don't always react in an adverse way in the patient. But they often do, and therefore they must be managed. Similar to DDIs, drug-drug interactions don't always put off an adverse drug effect, but they often do. And once they're known to exist, they must be managed. A physician would be negligent in not managing known drug interactions, and since we are able to discover 40% more, those 40% more need to be managed once they are discovered in these patients that are exhibiting signs and symptoms of an adverse event. I'm going to turn it over to Dr. Jeter.
As Joel was saying, Interact RX is a diagnostic test, and as such, Interact RX would not be expected to directly change health outcomes. There's no evidence that Interact RX is either therapeutic in and of itself. Rather, it's a diagnostic test that affects health outcomes through changes in disease management brought about by physician actions taken in response to test results. Such actions include the decision to treat or withhold treatment, to choose one treatment modality over another, or to choose a different dose or duration of the same treatment. And I will read from one of CMS's NCDs. It's the final coverage decision memo for the FDG PET to guide initial management of cervical cancer. Whether or not patients are better off from undergoing a diagnostic test will depend on how test information is used to guide subsequent decisions on starting, stopping, or modifying treatment. Consequently, the practical value of a diagnostic test can only be assessed by taking into account subsequent health outcomes. When a proven, well-established association or pathway is available, intermediate health outcomes may also be considered. For example, if a particular diagnostic test result can be shown to change patient management and other evidence has demonstrated that those patient management changes improve health outcomes, then those separate sources of evidence may be sufficient to demonstrate positive health outcomes for the diagnostic test. And this isn't a single NCD that has this language. Two additional ones, and there are actually more, that contain similar language, if not the same. One is on the decision memo for PET FDG for solid tumors. We believe that evidence of improved health outcomes, such as treatment options offering prolonged survival and diagnostic evidence supporting changes in therapeutic management, is more persuasive than evidence of test characteristics. The third NCD is basically a statement that says CMS is most focused on assessing clinical utility to include whether use of the test to guide patient management and treatment improves health outcomes. And I will read from a policy that is also out for consideration, and this is directly quoting from it. While there is no randomized controlled trials of outcomes using the Decipher biopsy test, numerous studies from different institutions have all had similar and consistent findings, providing evidence that this test accurately risk stratifies patients based on genetic information. Obviously, Interact RX is not a genetic test or anything, but the criteria should be the same. And here's the clincher. While research has not definitively shown that such risk stratification improves outcomes in terms of either better prostate cancer outcomes or overall reduction in treatment-related adverse events, There is sufficient evidence that this test is able to better perform patient and clinician decisions that must presently be made in the state of significant uncertainty. This is the standard that a decision for a positive coverage is being put forward for a draft LCD that is under consideration today. And yet, with the randomized controlled trials and definitive evidence, our test is being denied. I'm going to turn it back to Joel.
Thanks, Elaine. Thank you, Dr. Gier. I'm going to, for brevity purpose, I may skip ahead here. I mentioned that drug-drug interactions are intermediate health outcomes, and gave the example of cholesterol level testing. With a cholesterol level test, you would not be expected, if you can show that a new cholesterol level test acts similarly to a cholesterol level test in performance-wise in diagnosing cholesterol levels, that you would then need to follow those patients to show that there are better health outcomes as a result. That is a known. We know that that is going to occur, just like we know, and just like the draft policy does correctly state, that with drug interactions, many are known to cause adverse health outcomes. They are a significant cause of morbidity. Just because not all of them will does not mean that not all of them need to be managed. If they are known, and this is a better way of finding them when patients are exhibiting signs and symptoms, they must be managed, and management is known to cause better health outcomes. The results of the study quickly are, again, 99% of physicians reported that they are performing the current standard of care. However, they're only diagnosing DDIs or recognizing them 15% of the time approximately. Comparing the groups, doing a group with just the current standard of care to those that had the standard of care and then were able to use the test, those doctors were able to identify drug-drug interactions 40% more of the time. This in turn resulted to drastic improvement in the rate of counseling patients on DDIs. Round 1 to round 2, there was a 250% improvement. There was a drastic discontinuation of the offending agent that was creating the DDI once it was known, 40% of the time. Again, we think it's axiomatic that there is stated another way, following the national coverage determination language, there is a known pathway from the intermediate health outcome to the outcome. The outcome will follow, and there will be improved patient outcomes. In summary, the drastic improvements were seen in patient care when providers treating patients with drug-drug interaction signs and symptoms received the test. They had improved recognitions of drug-drug interactions, which were adversely impacting patients. There was an improved ability to identify the specific substance causing the drug interaction. There was improved medication management that was studied and shown through the studies. There was increased patient counseling on the dangers of drug interactions, and there was increased coordination of care with other physicians.
So we've had the privilege, amicus curiae, a friend of the court, to do quite a few studies over the years. We've looked at different diagnostics, molecular and otherwise, and we've used a method that some of you are familiar with. We use simulations to do that. This is used in a number of industries. Healthcare has come late to this. We now use this in the clinical practice setting to standardize care. But it offers a safe, affordable, and lower cost method for determining clinical utility. We find that it's most useful when it's difficult to collect patients that are affected, when there's patient harm, and when there's no benefit. Joel and Elaine talked about how in the case of drug-drug interactions and Interact RAX, we're concerned about patient harm. We know that there's a benefit from stopping this, so there's an ethical question. Do we continue allowing our patients? We know that doctors like me report all the time that they're checking for medication interactions 99% of the time, but in fact the data shows that they do so 15% of the time. And we know when they're armed with this new diagnostic that their practice improves. So we use these simulations because we know that they're validated against actual practice. We know that the data is clean. It doesn't require unique extraction from the medical record. We know that we can accelerate the evidence generation so that we can find out which tests work. We have two studies here today that do dramatically We have other products and studies where, frankly, the results are not as meritorious. We can get it from the sample size, we can determine the use case very specifically, and we can introduce the increased rigor that we want to do so. And we do so from an academic perspective. This is just a small sample of some of the publications that we've had in this space recently, looking at the approach there. My last comment is that when we see a large effect, a remarkable effect, like we've seen with Aegis and the drug-drug interaction test, it gives hope that there's a technology and a diagnostic out there that will change practice.